too, though.
All right. Let's
There you
change
go.
that. Okay.
Okay.
All
Ah,
right. All right. So Jamila's joined us. That's wonderful. And our first speaker says she'll be getting on momentarily. So I guess I'll just start speaking at the 8 o'clock.
hi, Dr.
You can
Jamila.
hold on. You can
I-
hold on for the first speaker. Maybe you can allow 1 or 2 minutes.
Okay.
Um, but Sarah should put on the slide and she can go live on time and maybe play some music, any music that you can find that is neutral. Sarah, please put up the poster.
Hi, Dr. Villaseca. Thank you so much for joining us. You're on mute.
Excuse me for the confusion.
That's okay. I'm glad you joined us. Thank you.
Okay, that means you're ready to go.
Okay. So I can let me
So
know when to
Sarah, you
start
can go
talking.
live.
Is this still practice?
So when you go live, then you spotlight Sharon so she can start.
Good morning. Good morning. My name is Sharon Sledge. I'm the Patient Blood Management Coordinator for the Bloodless Medicine and Surgery Program at NYU Langone Health and also our Pediatric Blood Conservation Program. I'm also a member of the Society for the Advancement of Patient Blood Management. So we just want to again give everybody a warm welcome for joining us for our second day of the Bloodless Medicine and Surgery Week. And I must say, we got it off to a fine start yesterday. We had some wonderful speakers and a lot of excellent information was portrayed. So I just want to remind everyone that May is Bloodless Medicine and Surgery Awareness Month, and the Bloodless Medicine and Surgery Week in the month of May is meant to really raise awareness about and provide education about bloodless medicine and surgery as really a superior form of healthcare. And it's organized by the Bloodless Medicine and Surgery Group at the University of Calabar, Nigeria, in collaboration with the Bloodless Medicine and Surgery Society, the Society for the Advancement of Patient Blood Management, and the Malaysian Society of Patient Blood Management. The theme for Bloodless Medicine and Surgery Week 2026 is Principles and Practice of Transfusion-Free Haematology. And certainly all of us in the field know how vital hematology is to us giving the best possible care to our patients. So at this time, I would like to introduce my co-moderator. He said I can introduce him as Dr. Kevin, but he is Dr. Kevin Ne Wei Shang. He's a consultant anesthesiologist in Sumbar Jaya Medical Center in Malaysia. So I'll turn it over to Kevin at this time.
Yeah, hi, welcome everybody. It's very nice. Thank you, Sharon, for the very kind introduction. I think we are all good, ready to go. We're going to have three very good speakers today. We're going to start with Dr. Alicia, followed by Dr. Jamila, and ending with Dr. Jonathan. We'll be talking about three very interesting topics. We'll get to it in a while. Just a few housekeeping rules. All questions should be placed in the Q&A. Let's minimize chats during the talk so not to distract everybody. The program is also being streamed live on the BMSS YouTube channel. In case anyone has difficulty with Zoom, the YouTube link will be shared in the chat. or you can search it on YouTube as the Bloodless Medicine and Surgical Society. Right. Without further ado, I think we can get started. I'll hand it back to Sharon for our keynote speaker, Dr. Alicia.
Right. So I'm gonna introduce to you now. It's my great privilege to do that. Dr. Alicia Beatriz Villaseca. She's a hematologist and internist and specialist in hematologist with expertise in management of thrombosis, bleeding, and anemia in the perioperative setting. Dr. Villaseca grew up in Buenos Aires, Argentina, and she graduated from the University of Buenos Aires. She's an active member in the Argentinian Society of Hematology and the Argentinian Group of Thrombosis and Hemostasis. She participates in the advisory board of these two societies as an active member. Dr. Villaseca was president of the Argentine chapter of SAI PBM from 2023 to 2025. She's also was the president of the Argentine chapter of that society, Sociedad Ibero-Americana de Patient Blood Management from 2025 to 2027. She was professor at Maimonides University for 4 years. And up until that date, she was also a professor of resident students at the postgraduate course of anesthesiology of the Argentine Association of Analgesia and Anesthesia and Reanimation. She also, up until that date, was professor in the higher postgraduate course for hematologists. Dr. Villaseca's papers and her lectures cover the areas of deep vein thrombosis prophylaxis, perioperative bleeding, patient blood management, and anemia in the perioperative setting. She is currently the chief of hematology department in the private surgery clinic, San Camila in Buenos Aires, Argentina, and she's also an active full member of the Bloodless Medicine and Surgery Society, which she recently joined. So at this time, I'll turn the meeting over to her. We await her very intriguing, no doubt, lecture.
Okay. Thank you very much, Shannon, for your presentation. I'm going to share the presentation. Can you see well?
We can see your slides. Just put you. We can see it. Thank you. I believe there's an issue with the audio.
Dr. Alicia, can you hear us? Dr. Alicia, we can't hear. The video is not playing the sound.
Dr. Alicia, mhm. We still can't hear. Perhaps maybe we should go to the next speaker and see could we figure it out.
Is there any problem?
Now we can hear you. We missed your whole presentation so far.
Okay.
Could you restart? Thank you so much.
Okay.
Thank you.
Well, can you hear me now?
We can hear you, but when the video plays, we can't.
Can you hear?
Nothing is showing now. We don't see anything.
You have to share your sound.
Yes.
Okay.
But I don't know why it don't function today. Share the presentation. And share the audio.
Slideshow.
I hope now it functions.
Okay. Mhm.
Vilasaka, I can share
Hey.
your slides.
Now you can hear me?
Yeah.
Yes, can you
Yeah.
stop sharing and I'll share it?
Okay. Do you
Could you
want to
start it from?
change the order?
No, can you start it from the beginning with her slides? Because we didn't hear it. Okay. Is that the first slide?
Yes, this is the first slide.
Okay. So Sarah, can you do her slides for her? And Dr. Alicia, if you could just tell her when they advance the slide, and she'll do that. Okay. Okay. Okay, you could just start speaking anytime, and you just tell her when they advance the slides. Thank you.
Okay.
Mm-hmm.
Well, excuse me for the problems. I
That's
don't know
okay.
what happens. So it's a pleasure for me to stay here and to be invited for the board. So we are talking about the global burden of anemia. Can you hear me or you are here the presentation?
We can hear you.
Okay. Well,
Mhm.
as you know, the global burden of anemia continues to remain a major public health concern globally in all the world. And you have to know that the WHO have put a new information from women's. Okay. And we know that the perioperative anemia and iron deficiency in the triad surgical is a very important issue with a prevalence to 10 to 75% of surgical patients, and it have 2 and 3 times higher risk of transfusions. But the key bullet points are the increase of morbidity, mortality, and prolonged recovery. So we need to action about anemia and iron deficiency anemia. Identify, investigate, and optimize it. It's very important for the outcome of the patient. The next, please. Iron deficiency is the silent risk factor for the patient and for the anesthesiology. And why? Absolute iron deficiency without anemia is the body iron stores insufficiency. But iron deficiency is the disease. We need to know that the disease is iron deficiency and anemia is the consequence. And how to detect it? Well, normally in a patient without inflammation, we have a low ferritin, low from 100, low transferrin saturation from 20, high values of soluble transferrin receptor, but we have hemoglobin levels normally. So if you don't use the iron profile, you don't detect it. It is not sufficient with seeing only the hemoglobin. And we need to make a differentiation without absolute iron deficiency and functional iron deficiency. I tell to my students that if you don't know very well the iron profile, you need to use always the transferrin saturation, because the transferrin saturations give you the information if really the patient have or not have iron viability. So in patients with inflammation disease like heart failure, chronic kidney disease, or cancer, the ferritin is higher because it's the inflammation. But if you don't have the transferrin saturation, you don't know if there is or not is viability iron. The next, please. So what happened with you haven't enough iron in your body? Viability, or really you don't store of iron? Normally, all the patients, all the people and all our colleagues, not hematology colleagues, think about erythropoiesis. But iron is important in all the body. In cardiac, please, can you go? Yes, thank you. In the cardiac system, the iron have a very important function because it form part of the myosin molecule, very similar to hemoglobin, and also in the contractility. So when you have a patient with iron deficiency without anemia, this patient have hemodynamic instability, reduced contractility, increased risk of ischemia, decreased function class, It is also a very common and up-to-date comorbidity in heart failure patients. And nowadays, cardiologists look at this in her patient with heart failure. So this is the first system that we can see iron is very important, not only because the hemoglobin level and the oxygen transportation. The next, please. So we can see that iron is very important also at the nervous system. It is essential to myelin synthesis, neurotransmitter metabolism, cognitive impairment, also the quality of sleep, and from the anesthesiology, it is very important if the patient have a previous iron decrease, because the patient has a pre-existing neuronal dysfunction and may influence in the response to anesthesia and postoperative cognitive recovery, as well as increased risk of postoperative delirium. The next, please. And what about the immune system? Well, this is really a other important issue, because the patient with iron deficiency have also an immunologic dysfunction, because the deficiency of iron affects chemotaxis and bacterial function of neutrophils, as well as immunoglobulin system, antigen presentation by T lymphocytes. It increases the risk to infection. There is also a very important intestinal microbiome alteration, and for our surgical situation, it increased the risk of infection in the surgical site and postoperative sepsis. The next, please. And also it extends to the population of a pregnant woman, and it increased a lot maternal death. So we need to look and assist all the pregnant women to avoid iron deficiency. Continue. So perioperative anemia and iron deficiency is the most common and significant modifiable risk factor in surgery. So we need to pay attention not only to the hemoglobin level, we need to look in all the patients who have risk of bleeding to their iron profile. We think that the solution to obtain this is to use the patient blood management, because the patient blood management structure in 3 pillars try to optimize the red blood cell mass, minimize blood loss and bleeding, not only surgical bleeding, also the bleeding or the take to a lot of samples to laboratory and so on, that could be diminish the iron of the patient. And finally, optimizing patient physiology reserve in relation to anemia. This is a very important issue, because with a very economic and simple measure, you can make a very big change. The next, please. How to optimize the red blood cell mass? Well, it is mandatory to early screening all patients, not only with routine hemoglobin and iron testing for all elective myosurgery candidates. The optimal time to do this is 28, 30 days to surgery to allow for effective treatment. The treatment actually is with iron IV, because we have the advantage to bypass gut limits, faster hemoglobin response, And in my country and in Latin America, we use a lot carboxymaltosa, but there are other salts, EV salts. Now we have an oral alternative. I am talking about this after, that is sucrosomial iron. Sucrosomial iron is an oral iron very similar to an IV iron. The next, please. The intravenous iron, as I have said, we have two types using at this moment. Third generation irons like ferric carboxymaltosa or ferric derisomaltosa that give us the facility to give high doses in a single application. The second generation iron is cheaper, but have the you can all you need you bring the patient only 200 per infusion, so you need a lot of infusion to give the same to give a gram of iron, you need a lot of infusions. This is the Ganzoni formula to calculate the the quantity of iron you are going to bring to your patient. The next, please. When I talk about a new iron formulation, I don't talk about a new iron salt. I am talking about a new iron transporter. The sucrosomial iron is a new form to introduce the iron to the body. How? With a transporter called sucrosome. The sucrosome is a complex structure around the salt of iron. The salt used is pyrophosphato. This is a salt with high affinity to transferrin and is covering with a matrix of a sucrestan matrix, a polyphospholipid, a phospholipid matrix, and tricalcium phosphate. This sucrosome corpuscle could be received for all kinds of patients with alterations in their gut digestive structure, for patients with celiac disease, because it enters as a little lipid particle in the body. So this sucrestan matrix also tolerate the action of the digestive of the gastric juice, and it is don't alter in high pH. The next, please. The other advantage of the sucrosomial iron is that have a unique mechanism of absorption. It can be enter the body avoiding the dimetal transporter, so it enter by enterocytose or transmembrane or paracellular or by the M cells. So don't use the dimetal transporter and don't use ferroportin. So it is not blocked by epsidin. And the next, please. It is rapid, has a rapid effectiveness because this iron intact, the most molecule is intact, rich intact the hepatocytes, and there is degraded by lysosome enzymes. And the pyrophosphate salt is immediately ion with transferrin and go to the places the iron is needed. The next, please. The independence from epsidin and this unique mechanism of absorption make it a very interesting alternative. The next, to use when we can use IV iron because the cost of the drug and the cost of the use of the health facilities to put in the patient. Another characteristic of this iron is it dose depends, because if you increase the dose, you can reach a rapid increase in hemoglobin. This is different with the conventional iron because if you increase the dose, the divalent transporter will be saturated, and the iron not absorbed is free in the gut and is pro-inflammatory. And this raises the hepcidin, and the rises of the hepcidin block the use of the iron you are doing. So you have not, if you increase the dose with the traditional salts, we have an hemoglobin increase reaches a plateau, and then the patient have a lot of symptoms of gastric intolerance. The next, please. Other therapeutic alternative to optimize red blood cell mass is in some patients, particular patients undergoing major blood loss surgery. You can use iron and erythropoiesis stimulating agents. But remember that you need to always administer iron if you use erythropoiesis stimulating agents, because if you don't use, you have not the adequate response. The second pillar is the strategies to intraoperative conservative of blood. This is not minimizing blood loss with surgical precision, minimal invasive surgery, anesthetic precision, blood recovery when you have the blood cell saver, a good management of hemostasis, the universal use up to date of tranexamic acid, topical agents, viscoelastic texting, and I always remark the importance to control the three variables that can guarantee that the hemostasis function well, that at temperature control, pH control, and calcium control. Because calcium normally not only is affected by the transfusion citrate, it is affected also by the temperature and the pH. And also, please, the other written one.
Mm.
No. One. Yes. It is very important to understand that in the second pillar, we need to prevent iatrogenic anemia, because it is common in some places that the patient have a lot of unnecessary laboratory test orders. We need to reduce the number of test orders all the days. We need to reduce the volume of blood draws, and we need to evaluate at the final of the patient contact with us if we are replacing all the losses of iron the patient has during his contact with the health system. We need to think that the blood of the patient is like the gold of the patient, and if we take it, we need to return it. The next. We are near the final of the presentation. So the third pillar is optimizing the patient physiological reserve in relation with anemia. There are few items that can help the patient and us to avoid unnecessary transfusion. The optimization of oxygenation. the use of adequate oxygenation with supplemental oxygen can optimize the patient. The adequate hydration, because the blood viscosity facilitates oxygen transport. The pain control, because pain increases your heart rate and oxygen demand. Always you can think also optimization heart function, because the use of very little dose of inotropic can stress volume for other zones of the body. And finally, of course, correction of anemia, if it could be possible because the patient is hemodynamic stable, pharmacological replacement. And if the patient is hemodynamically unstable, you can use the less unit of transfusions need to recover the hemodynamic stability. So you can start with only one transfusion, check the response of the patient, and take the second only if the patient don't reach the hemodynamic stability. The next, please. Why not to make a summarize of my presentation? Why not to take an anemic patient or an iron deficiency patient to surgery? Okay, because we know that we have more postoperative mortality after surgery, more acute kidney injury, more postoperative infection. There is a lot of evidence in the literature to make sure you are doing the well when you do this. So my key message, preoperative anemia is not just a transfusion trigger. It is a marker of reduced physiological reserve and is associated with death, kidney disease, infection, and prolonged recovery. In non-cardiac surgery, the mortality association remains even after excluding transfusion patient. So anemia and iron deficiency is the risk itself. It is not necessary the correlation with the need of transfusion. I put here some bibliography you can check, but the evidence is so high that for us up to date, this is a standard of care. The next, and I think is the final. So anemia and iron deficiency are silent but significant threats in the perioperative setting, impacting morbidity, mortality, and recovery. Patient blood management is not about just no transfusion. It is a comprehensive three-pillar approach, optimizing the red cell mass, minimizing blood loss, and optimizing the patient physiology reserve. This is the strategy to win against the silent killer. PBM recommendation, a perioperative hemoglobin level greater than 13 is recommended for potential bleeding surgery and regardless of gender. All patients undergoing a procedure are at risk with a risk of loss of more than 500 milliliters of blood should be previously cleaned for iron deficiency with or without anemia. It is not enough to check the hemoglobin. You need to check the hemoglobin and the iron profile. Blood is the river of life, so we need to take care of it. Thank you very much.
Thank you very much, Dr. Vilaseca, for that very informative presentation. I totally agree with you. Blood is the river of life, and it is essential that we correct our anemia regardless of gender. I think that's a very important message that we have to pass across. Just a quick note, to those that have questions, there is a Q&A option. Please put all your questions there so that we do not lose it in the chat. Like to proceed with our next. We'll keep all the questions to right to the end, and then we'll have our Q&A then. I'd like to introduce our next speaker. It gives me great honor to introduce Dr. Jamila Sata. I will read what has been given to me. Dr. Jamila Sata is a consultant hematologist and former head of Department of Hematology at Ampang Hospital, which is our specialist hematology hospital here in Malaysia, where she is responsible for the care of patients with thalassemia, hemophilia, thrombosis, and bleeding disorders. She was instrumental in developing national thalassemia and hemophilia programs to improve the care of these patients in Malaysia. She is also actively involved in promoting patient blood management programs to optimize patient outcomes. Dr. Sata is a member of many professional societies, including the Bloodless Medicine and Surgery Society, and she is the founding president and immediate past president of the Malaysian Society of Patient Blood Management. On a personal note, she is the inspiration for my journey in patient blood management. She was the one that brought me in and trained me. I think it's been 7 or 8 years ago, and it's been instrumental in promoting patient blood management in Malaysia. So it's a great honor to introduce you, Dr. Jamila. Over to you.
Thank you, Kevin. Thank you for the introduction. Let me share my slides. So, can you all see my slides? I'm going to put it slideshow. Can you all see my slides?
Yep,
Yes, we
slides
can.
are seen.
Yeah.
No problem.
Okay. All right. So I've been asked to talk about raising the hematocrit without blood transfusion, the evidence-based approach. So in my talk, I interchange hematocrit and hemoglobin. But as you know, hematocrit is actually is derived from the red blood cell multiplied by the MCV divided by 10. While hemoglobin is a direct measure, by lysing the red cells, and you're measuring the hemoglobin by light absorbance. So, let's start with a case. This is a 42-year-old woman presented with fatigue, dizziness, heavy menstrual bleeding, with a hemoglobin of 6.8, hematocrit of 20.4, a reticulated hemoglobin of 17.5, which is low. Yeah, we take anything 30 and below as iron deficiency, and a ferritin of 12. She was referred to us by the surgeon because she was scheduled for elective thyroid surgery in 3 weeks. So she was referred to us for anemia, and found out that she had actually heavy menstrual bleeding. So what would you do? Would you transfuse 2 units of red blood cells, start oral iron, give IV iron, give a combination of IV iron and erythropoietin stimulating agent, or delay surgery? Would you do this, that stop the heavy menstrual bleeding, give IV iron, or delay surgery? Or this, because she's symptomatic with a HB less than 7, so I will transfuse 2 units of red blood cells. Yeah. I think with all the webinars and the teachings on patient blood management, I think now I would say most will choose the first option. Yeah. But a majority still will want to transfuse because she is symptomatic with giddiness, yeah, and lethargy. And so RBC transfusion is often the default option to manage anemia. Where is the evidence? Actually, there is no good evidence. Most trials compared restrictive versus liberal transfusion, and the results show that restrictive strategy did not increase 30-day mortality or any secondary outcomes, that is cardiovascular events. So based on this finding, guidelines recommend restrictive transfusion and recommend that hemoglobin less than 7, red blood cell transfusion is likely to be appropriate. So guidelines unintentionally reinforce transfusion as a treatment for anemia, and HB or hemoglobin thresholds become numbers we treat. Yeah. This is a 20-year study taken from the National health survey in America, looking at all the adults who had blood transfusion compared with those who did not have blood transfusion. And they did a propensity matching and found that the all-cause mortality actually increases by 85% in those adults that were transfused, and increased cardiovascular mortality by 137% in those who were transfused with blood. And this is a study looking at the pediatric population in non-cardiac surgery, which shows that transfusion in red increases the in-hospital mortality by up to 3-fold. So back to case 1, when you lose blood, you lose iron, that's, without, that's, when you lose iron, when you lose blood, you lose iron, that's without any doubt. So what is the evidence-based treatment for these patients? IV iron, definitely. You can add on erythropoietin-stimulating agent if surgery cannot be delayed, tranexamic acid and hormonal therapy to stop the heavy menstrual bleeding, and to treat the underlying cause of heavy menstrual bleeding. It could be, if it's due to fibroid, you can then treat that, So we need to address the cause of the heavy menstrual bleeding. So let us look at the evidence, IV iron versus blood transfusion. So this is a systematic review looking at IV iron versus blood transfusion for iron deficiency anemia. There were 5 trials, of which 3 were randomized control study and 1 observational and 1 retrospective. The results show that IV iron results in a higher hemoglobin at 3 weeks, while blood transfusion, it increases the hemoglobin rapidly in the early phase, but falls off after 3 to 8 weeks. So this is the study. I've just taken one of the study, the randomized control study by Home, looking at women with postpartum hemorrhage. And the one in blue is IV iron, and the one in orange is blood transfusion. And you note here that those women who receive IV iron, and they started off actually with a lower hemoglobin of 7, had a higher hemoglobin at the end of 3 weeks, and at the end of 3 months, they have a higher hemoglobin compared to blood transfusion. So blood transfusion actually does not correct anemia. It does not correct the cause of the anemia, which is iron deficiency. What about the role of erythropoietin-stimulating agent? Yes, there are evidence that it can be used in preoperative anemia, where there is limited time frame, anemia of chronic disease or inflammation, such as cancer-associated anemia, and chemotherapy-induced anemia. So let us look at erythropoietin-stimulating agent plus IV iron in preoperative anemia. This is a systematic review of 25 studies, over 4,000 patients. Were in this systemic review, and the results show that with ESA and IV iron, it actually decreased the risk of transfusion, but there was no statistically difference in mortality or venous thromboembolism. What about ESA in cancer-associated anemia? Well, the evidence is conflicting in terms of mortality, disease progression, and VTE risk, because some studies show that actually mortality is reduced, and other studies show that it's increased in cancer-associated anemia. So are erythropoietin-stimulating stimulating agents tumor promoters? Well, as you know, EPO and its receptor is not an oncogene. Evidence suggesting tumor stimulation is mainly from cell lines and not from primary human tissue. There is no tumor growth seen in animal models with recombinant erythropoietin, and erythropoietin receptors are predominantly found on erythroid cells with minimal expression and very low binding affinity on non-erythroid or tumor cells, making meaningful competition for erythropoietin unlikely. So the erythropoietin receptors, will be binding to erythropoietin, with a treatment that you give them with IV erythropoietin. They will all go and bind to the erythropoietin receptors. So this was a study. I looked up a study to show that to compare patients with lung cancers undergoing chemotherapy, comparing those who had erythropoietin and with those without. And the study showed that, the meta-analysis showed that there was no difference in disease progression with erythropoietin stimulating agents. There were 5 studies that were looked into in this meta-analysis. So do ESAs cause thrombosis? Well, ESA increases red blood cell mass, so plasma volume decreases. So hence, full blood count is not an accurate surrogate for red blood cell mass. Studies have shown the higher the hemoglobin, above 12, the higher the risk of venous thromboembolism. And blood transfusion given together further increase the risk. So this was a study, it's a retrospective study looking at red blood cell transfusion versus erythropoietin stimulating agent in chemotherapy-induced anemia. And as you can see here, there is a more than 2-fold increased risk of VTE with red blood cell transfusion compared to erythropoietin stimulating agent. This was a paper by Breyer. So back to case 1. So that when the patient presented to us, hemoglobin was 6.8, and ferritin was 12, so we gave her IV iron, and on day 14 it went up to 8.9. I was not too happy with that, because she was still having her menses, so we added on more hormonal therapy, and her menses stopped, so we gave her another 1 gram. So I was worried that I couldn't bring up the hemoglobin in time, because the surgeon said they can postpone it by 1 month. So I gave her 1 more gram of IV iron here, and by date, and with erythropoietin at 4,000 units twice a week, and hemoglobin went up to 12.3. And I continued the erythropoietin till, and I stopped the erythropoietin here. And by day 42, the hemoglobin went up to 14.2, and the ferritin went up to 144. So she was all prepared for her thyroid surgery at the end of 6 weeks of treatment. So the lessons learned from case 1 is IV iron is the definitive treatment for severe iron deficiency. IV iron replenishes iron stores quickly. When time is limited, we can accelerate erythropoiesis with ESA after replacing with IV iron. Prompt cessation of bleeding prevents further iron loss. So I'm just going to talk about iron deficiency in cancer patients. I'm a hematologist, and I used to treat patients with hematological malignancies. And as you know, from the European Cancer Anemia Study, iron deficiency is very common, in cancer patients, 54% at presentation and 75% during chemotherapy. So they have taken a cutoff hemoglobin of less than 12 as a definition of anemia. And iron deficiency anemia is seen as is more common in hematological malignancies, 2 times more common versus solid cancers. And anemia in cancer patients can be either functional or a combination both of absolute and functional iron deficiency. So we did a retrospective study in our hospital. This was a preliminary data looking at the 3 months, from July to October, and all our patients, our newly diagnosed hematological malignancy patients, all of them would get a bone marrow examination. And in this 3-month period, we have extended it to 1 year, so we'll be publishing our data soon. In this 3-month period, we had 55 bone marrow samples, 25 were female and 30 males. And you can see the breakdown. Leukemia accounts for 56% of patients, followed by lymphoma and multiple myeloma. And this is the bone marrow iron stores. The one on the left, there's absent iron stores. We use a pearl stain to stain the iron. And the one on the left, there's no bluish discoloration, while normal iron stores on the right shows, blue pearl stains, iron stores. So results show that close to 80% of our patients had low or absent iron stores. And they're similar between males and females. So what was surprising, you would think that males would have higher iron stores, but no. Both males and females have very low iron stores at presentation, even before chemotherapy. So I'll just show you the case 2. 46-year-old lady married with 4 children, presented with abdominal bloating for 1 month. CT scan showed uterine mass with endometrial thickening. Hemoglobin was 6. She was transfused 4 packed red blood cells before the operation. She developed a particular rash, the 3rd bag, and fever during the 4th bag. So this was before the treatment. She was referred to the hematology. They found that she had a large ovarian mass, so they proceeded with a TAHBSO, total abdominal hysterectomy, with bilateral sphincterectomy with pelvic node clearance, and the HPE came back as Burkitt's lymphoma. Burkitt's lymphoma is a very, very malignant lymphoma. So she was referred to us. At that time, hemoglobin after 4 bags of blood was 9.3. She was given high-dose chemotherapy because it's a very aggressive lymphoma, with rituximab and AB block, with high-dose methotrexate and alternating with high-dose cytarabine, arabinocyte, 3 pairs. So she was admitted after the 5th cycle of chemotherapy under my care, I think because there was no beds in the other wards, so she came under my care. So she was recovering from sepsis with a hemoglobin of 5.7. I continued on with antibiotics. I started her on erythropoietin, IV iron, folic acid, and vitamin B12. No blood was transfused, and she remains well and in remission. So I'm just going to show you the full blood count trend of this patient. I'm just going to start off after the first 2 cycles. So the arrow is where I saw her, after the 5th cycle, where hemoglobin was 5.7. So for the first 2 cycles, she had an average of 3 packs of red blood cells, because after chemotherapy, her hemoglobin will fall to, around 5.5, So she's always given 3 to 4 bags of blood in all her chemotherapy. For the first 2 cycles of chemotherapy. So here's where I saw her. Hemoglobin was 5.7. I didn't give her any blood transfusion because she was stable. She looked pale, and it was already day 10. So, you expect she would be recovering soon. So I started her on IV iron and erythropoietin stimulating agent. She was already on GCSF, and she was discharged home quite well. And when she came in for her final chemotherapy, her hemoglobin was 9.8. I immediately gave her IV iron and started her on erythropoietin. And also after the chemotherapy, I didn't wait for the white cell count to fall. I already started her with GCSF. And by day 10, as you can see here, hemoglobin went down to 8.7. In the past, it will go down, to about 6 or even less than 6. And she was fine. She completed the chemotherapy, and by day 35, her hemoglobin was 12.3. And she's been in remission since, and she's very well. It's now 6 years since the treatment. So the lessons learned in this case is, before chemotherapy, I would correct iron deficiency with IV iron, because most of our patients are iron deficient before even starting chemotherapy. That's pillar 1. During chemotherapy, I would treat her with erythropoietin stimulating agent and a small dose of IV iron, and I would reduce blood taking. That's pillar 2. And after chemotherapy, I would accept a lower hemoglobin level. And before I send her home, I would give her a bolus dose of erythropoietin and IV iron and B12 and folic acid. I've added all that in. All right. Just to show you, we did a study looking a 4-year period, looking at the effectiveness and safety of intravenous iron for anemia in hematology patients at our hospital. So most of the patients that are admitted in our hospital were all patients with hematological malignancies, but we also included the ones with ITP, PNH, paroxysmal nocturnal hemoglobinuria, and hemolytic anemias. And what we found was when we compared those who had IV iron compared to those who had blood transfusion only, IV iron only, and blood transfusion only, HB increment at 8 weeks was 3.5 with IV iron versus 1.1 with blood transfusion. And blood infections, we always think that, IV iron increases the risk of blood transfusion, but it's not true. As you can see here, blood infections was 8% with IV iron, and with blood transfusion, it was 22%. So in conclusion, what we concluded from our study is IV iron was more effective and safer than blood transfusion in correcting anemia among adult hematology patients. We will be publishing it soon. So my take-home message is transfusion is not a treatment for anemia, right? The most common cause of anemia is iron deficiency, and IV iron rapidly corrects iron stores, and erythropoietin-stimulating agent accelerates erythropoiesis in preoperative anemia and cancer patients. I think that's my last slide. Thank you very much. I go. Yeah. I kept to my time, right? Yeah.
You got us back on schedule. Thank you so much. So,
Thank
and
you.
again, thanks for coming here and presenting to us today. I think you very expertly used the evidence to show that really a lot of our hematology colleagues, that blood should not be the automatic default to treating anemia. And you showed expertly how you were able to do that. And so I'm hoping that some of our colleagues on the line will take what you said and what you presented to heart today. So thank you so much. So now we're going to go on to our final talk for the session this morning, and that's going to be presented by Dr. Jonathan Waters. For many on the call, he needs no introduction, but of course it wouldn't be appropriate to bring him on without one. So I'll try to do him justice. So Dr. Jonathan Waters, he's an emeritus professor in the Department of Anesthesiology and Bioengineering at the University of Pittsburgh. He was the chief of the Division of Anesthesiology at McGee Women's Hospital of the University of Pittsburgh Medical Center and a member of the McGowan Institute for Regenerative Medicine. In addition, he was the medical director of the Patient Blood Management Program at UPMC and medical director of the Blood Management Division of ProCirca, Inc., which is a UPMC-owned biomedical engineering company. Dr. Waters' areas of expertise primarily focus on transfusion management, blood salvage, and obstetrics. He's been federally funded to support investigation in these areas with over 150 peer-reviewed publications, 5 books on the topic of blood management, and a book on neurologic disease and pregnancy. In addition to conducting research, he served on the editorial board of the Journal of Transfusion and is currently serving as an associate editor. Dr. Waters is a past president of the Society for the Advancement of Patient Blood Management. He also served on the board of directors of AABB, the American Association of Blood Banks, between 2011 and 2015. He's chaired the Blood Management Technical Advisory Panel for the Joint Commission for 2007 to 2016. Dr. Waters is also a member of several professional societies, including the Bloodless Medicine and Surgery Society, and he was the recipient of the 2023 Award of Excellence of the Society for his excellent contributions to science and the practice of bloodless medicine and surgery. So we eagerly await Dr. Waters' talk on what is wrong with perioperative autologous blood donation. Jonathan, we'll hand it over to you.
Thanks, Sharon. Can you see my slides?
We can, yes. Mm-hmm.
Okay. I'm going to deviate off of what is normally considered part of patient blood management. We're going to talk a little bit about waste. And one of the big sources of waste, at least when we started tackling waste in our healthcare system, was preoperative autologous donation. So I'm going to talk about that, the reasons that we got rid of it, and then potential alternatives to providing autologous blood to your patients. So, first of all, some definitions. I want to make sure that everybody understands what autologous blood is versus allogeneic. Autologous comes from oneself. There's three forms that we can provide it to patients. One is through preoperative autologous donation, where you donate the blood before a surgical procedure. Another is autotransfusion, or what is commonly called cell salvage or cell saving. And then there's uh, a type of therapy which has been labeled ANH, but the ANH stands for multiple different things. But in general, autologous normovolemic hemodilution is what ANH stands for. And then allogeneic blood is blood that you get from somebody else, which is the classical blood that you get from the blood bank. So, like I said, I was going to talk about waste. This is the strategy that we developed at the University of Pittsburgh for our blood management program. Primarily, it was to get people to use evidence-based transfusion guidelines, but the number two step in our program was to reduce all forms of waste related to blood transfusions. And waste is really important, as pointed out by Don Berwick in this article published in JAMA in 2012, that waste, at least in the American healthcare system, is about a third of all healthcare spending, which for the United States is about $1 trillion. So it's a huge impact on our healthcare system. And this is $1 trillion that could be used in other ways, and hopefully some of it would go to physician and nursing salaries, but that'll never happen. It'll all go to the administrators. At any rate, Berwick pointed out these sources of waste, and I think for preoperative autologous donation, overtreatment is probably where you might find this particular therapy to fall. And like I said, the size of waste in the American healthcare system, you can see on the far right-hand side of this slide, is about $1.2 billion or trillion dollars, which is a lot of money. So sources of waste in healthcare, these are a list of where we found them to be existing in our system. Again, number one on the list is preoperative autologous donation. So what is it? It's where you basically donate blood for yourself prior to a surgical procedure. And it's done in the same way that a normal blood transfusion would take place. It's typically done in conjunction with iron therapy to hopefully keep your iron stores in a normal status. And typically 1 to 2 units are harvested during this process. Sometimes more than that, but in general, most of the time that I was faced with this particular type of therapy, it was 2 units. Some of the donation criteria or circumstances are illustrated here. The differences between allogeneic donation and autologous donation. Typically, with autologous donation, you'd be donating blood down to hematocrit level of 33% or hemoglobin of 11, or those of you in English-speaking countries, 110. There's no donor criteria that there would be for somebody donating an allogeneic unit. And because of this, blood that's donated autologously, preoperatively, is thrown away because it doesn't have the same safety criteria associated with it. And oftentimes people will suggest just put it into the blood bank stock, but because of the lack of safety associated with it, it's discarded rather than putting into the overall blood bank stores. This blood is only used for the donor. So What are the risks of autologous blood versus allogeneic blood? Autologous blood was pioneered really in the day where HIV was prominent. So the thought was is that through autologous donation, we could avoid the risks of viral transmission and HIV. There's also no immunologic reaction to autologous blood because it's blood from yourself, so there's not an autoimmune response that would occur. Other things that can occur with it is clerical error. You can deliver the blood unit to the wrong location, or just distribute it to somebody that it wasn't intended for. It can also be bacterial contaminated because it is stored for a period of time, and the things like volume overload are not avoided through autologous transfusion. One of the other things associated with autologous preoperative donation is the storage defect, which is illustrated here. These are red cells that have been stored for various periods of time. And in the upper left-hand corner, you see a normal red cell, which has the biconcave shape. And then over period of weeks of storage, the red cell takes on different shapes. It goes from a biconcave disc to basically an echinocyte, which is shown on the far right upper row. Then the spicules on that echinocyte slowly get shed off. So you end up with a spherocyte, which is shown in the lower right-hand corner. And this particular type of red blood cell, after it's been stored for a period of time, and the storage defect occurs over a period of about 2 weeks of storage, and that you go from the biconcave disc to an echinocyte, changes the ability of this cell to flow through the microcirculation. And I'm going to show some video of what that looks like here. This is the microcirculation from an animal. This is a rat model where what you'll see is multiple capillaries that are flowing vigorously. And as you see here, the red cells are flying through these capillaries at breakneck speed. And this is the same animal after it's been transfused with blood that's been stored for 2 weeks. And what you'll see here, off in the center, off to the left in the center of the slide is one of these echinocytes, and you're going to see that it's basically plugged up this capillary. You also see that the red cells don't move like they were before. It's more like sludge. So this is theoretically, what happens with storage to our red cells and their ability to move through the microcirculation. So those are some of the problems with preoperative autologous donation. This is a report that shows transfusion-related fatalities associated with the transfusion of blood. And what you see, again, is the bacterial contamination, transfusion errors, and TACO are things that you don't avoid with autologous donation. So a lot of these fatalities would not have disappeared with the use of autologous blood during the course of a surgical procedure. So the benefits of autologous donation were primarily driven by HIV contamination of the blood supply back in the late 1990s, as is shown by this slide. But over time, as we've done screening of donors, and there's basically viral testing, and now there's viral solutions that can negate the effect of viruses within a blood transfusion, that these risks are negligible. You can see in 2010, the chances of contracting HIV from a blood transfusion were 1 per almost 2 million. This was a mathematically modeled number. This wasn't a real number. And my understanding is that there hasn't been an HIV case contracted via a blood transfusion in the last 10 years in the United States because of the efforts that the blood bank community has done to try to minimize the impact of this particular problem. So it really has negated the reason to do preoperative autologous donation in the first place. So some of the risks, it's interesting to look at this, the incidence of hospitalization during donation, the risks during somebody donating a blood unit for allogeneic use or use by a blood bank is about 1 per 200,000. This is usually syncope. You can see for autologous donation, the rates are about tenfold higher. And the reason is that these patients are just not as healthy. And again, syncope is the major cause. So we're not getting much benefit from this particular therapy, and there is some risk associated with it. So what about the efficacy, of autologous donation? These are a couple of studies that looked at the cost effectiveness of allogeneic or autologous blood. And, oops, excuse me. Let me see if I can figure out how to shut this. I don't know why. Okay, we're back to stage 0. Sorry about that. So at any rate, you can see from this slide that the cost of providing autologous blood during orthopedic surgery is extremely high. Looking at the first study, somewhere between $200,000 and $740,000 for quality adjusted life here saved. And generally, when you're looking at quality effectiveness, a dollar figure of 30,000 is considered the kind of the cutoff between being effective versus ineffective. So something in the range of 200,000 would fall into the criteria of being highly cost ineffective. In our hospital system, what we found is that the utilization rate of preoperative autologous donation was extremely low. Overall, 50% of the units that were being donated were being used and 50% of them were being discarded. And that's one of the things that is not included in the costs associated with autologous donation is the cost of getting rid of these units, which comes with a cost. So we have a fairly cost-ineffective strategy. And to summarize, this was a study that looked at from a systematic review of autologous donation and found that it basically favored not doing it by about 30%. So as is demonstrated here in their analysis. So why is this? This slide basically illustrates this fact, is that if you take somebody and you bleed them down when they're starting with a hematocrit of 45% versus 30%, these parallel lines in the middle of the graph show that drop in hemoglobin or hematocrit as one bleeds, which is illustrated on the y-axis, the estimated blood loss. And you can see somebody that starts with a hematocrit of 45%, they're going to cross over a magic transfusion trigger of 25% hematocrit with a much larger amount of blood loss than somebody that's starting off at a 30%, which is oftentimes the case when somebody's pre-donated blood. So our 50% wastage rates came with a cost, and this is the dollar figure that we put on that wastage cost. This was just the cost of donating these units for our hospitals. This is not the cost of getting rid of them. And this cost is at a relatively conservative $200 per unit. Now blood in the United States is more expensive than that, but when this slide was created, that was the cost. So over time, we started an effort, most prominently just to educate our surgeons to get them to decrease sending patients to the blood bank for donation of autologous blood. You can see our efforts took quite a bit of time, about 9 years, to go from 2005 to 2014 before we were able to eliminate this process of autologous donation. So that all being said, what can you do as an alternative? And I'm a big advocate of cell salvage, as is illustrated here. This is where you collect the blood from the patient. You wash it, you filter it, and you give it right back to the patient. And I think this is a way of providing the patient healthy, normal cells that have not been subjected to a storage defect that I showed earlier. Um, Another solution is normovolemic hemodilution or autologous normovolemic hemodilution, ANH. This is where blood is removed from the patient at the start of the surgical procedure, and blood is replaced with volume expanding fluids such as crystalloid or colloid. I think I found it easier to do it with colloid, but colloids are becoming unfavorable in many people's eyes. Anyway, how you do this, you get a blood donation bag, such as shown here. And the easiest way to do it is illustrated by this slide, where an arterial line has been placed into a patient. A hep lock has been placed on that arterial line, and then one of these donation bags is spiked. And this bag, shown on the floor of this operating room, is filling with blood, and it's sitting on top of an agitator, so the blood is mixed with citrate constantly. And also, there's a scale within this device that weighs the amount of blood that's flowing out of the patient. In general, there's 63 mLs of citrate within one of these donor bags, so it can accommodate about 450 mLs of blood before it surpasses the ability of that citrate to anticoagulate that unit of blood. So you don't want to end up with a bag of clot. So you want to be careful with the amount of citrate that you're mixing with the blood. So theoretically, the value of hemodilution is shown here with these beakers, where you take the beaker on the far left is full of red cells, and you pull off a unit of blood, as is shown on the far right, and you store that unit of blood so that the patient is losing blood at a lower hematocrit during the course of the surgical procedure. And then at the end of the procedure, you take that patient who is now significantly anemic, you pour that blood back into them, and hopefully you restore them to a higher level and theoretically avoiding a red cell transfusion. Personally, I think that the red cell savings from this type of procedure is not that great. And there's very few clinical studies that have shown a clinical impact of it. But I think that the value is best when hemodilution is combined with cell salvage, so that you have the cell salvage providing red cells, and you have the red, or rather the hemodiluted blood that you've collected providing platelets and plasma for any coagulation defect that's occurred during the course of the surgical procedure. So you've got all bases covered. And with this combination, I've been able to take people through about 13 liters of blood loss without going to the blood bank. And that's a pretty significant amount of blood loss. And I know personally, because I did this with my father, who had a major spine procedure, an 8-level spine fusion and instrumentation, where he did lose 13 liters. And we combined it, a hemodilution with cell salvage, and he was able to get through this procedure without allogeneic blood being transfused. And he ended up spending only 4 days in the hospital, despite his insurance company having predicted that he'd spend 13 days in the hospital. So I think that's one of the major benefits of of blood management intraoperatively is that you shorten the patient complications and ultimately the hospital stay for patients that you've taken some effort try to avoid allogeneic transfusion. So, in summary, what I would suggest is getting rid of preoperative autologous donation. Keep the blood in the patient. It doesn't like being put into a plastic bag, and use alternative techniques to try to minimize the exposure to allogeneic blood. And so I will stop there, and Sharon, the table is all yours.
Thank
Excellent
you. I think Kevin will
presentation.
take it. Mhm.
Yeah, excellent presentation, Prof. I totally agree that PAD has it's probably not the best way to go, and but we here in Malaysia we still have some use for it, especially for very rare blood groups. We still do practice it, but generally I think most of us have moved away towards cell salvage and ANH. Right. As you can see from all the applause from everybody, we've got quite a lot of questions, and we'll try and go through each one. Before I start the questions, I'd just like to get just highlight one very interesting comment here from Awana. How do bloodless medicine teams keep patients safe while minimizing blood loss? I think it's a very overarching question that's come about, and I invite the panelists. Would anyone like to start as a first answer to give the first answer to this?
Well, I'll take that on.
Yep.
I think R.A. Shander showed it in his bloodless program at Inglewood Hospital in New Jersey. That patients undergoing cardiac surgery had better outcomes and better survival when bloodless was applied to their cardiac surgery exposures than the patients that didn't have bloodless techniques applied. So you get better outcomes, and I think I've seen that over and over again. If you use blood transfusions or allogeneic blood as the last resort, I mean, I think you can keep patients safe. Thinking of that as kind of the last end of a pipeline of different therapies that you can apply. But overall, I think your patients are much better off with bloodless strategies being applied.
Mhm.
Right.
There's
Dr.
another.
Alicia
Mhm.
or Sharon, you were saying something?
No, I was
Yes.
going to go ahead. Another question. Go, Dr. Alicia, that would be great. Please comment by all means.
I want to say something. We talk about bloodless medicine and surgery, but the focus in general is put a lot of time in surgery. And I think that in some hematology patients, like myelodysplastic and myelofibrosis, when they are anemic and don't respond to the therapy, we need to be very careful about the need of the real need of the transfusion is the only the hemoglobin level of the clinical, or we need to look of the clinical status of the patient. Because if you are very aggressive with the transfusion, looking at the hemoglobin, probably you transfuse more than that really is necessary. So I try to keep in my mind all the time this, and really the patient go best if you are not very aggressive and don't be afraid about the number of the hemoglobin because the patient tolerate it well. So I think that we need to transmit this to our college, to our clinical specialties, because in surgery it is more common that the change is coming. But in the other specialties, it's not so common that our colleagues tolerate low hemoglobin levels.
Yeah. One last comment from Dr. Jamila. I think you shared how we avoided transfusion in two patients, isn't it?
Yes, I think especially in hematological malignancies, right? We always think that, patients with leukemia, lymphomas, when they're on chemotherapy, they eventually will need blood transfusion. Actually, I illustrated in the case of, the lady with Burkitt's lymphoma. So what happens when you give chemotherapy? You have that nadir at about, 7 to 10 days. Yeah. So, and then after that, the bone, your normal cells have a survival advantage. They will come up quickly. So you just need to be patient, because they will, you will recover. So you need to give all the fuel like iron and erythropoietin to hasten it, So it actually, when you start treating patients, it actually works, So yeah, just
Yeah,
remember
I
you
think
just have that period, that 1 week period that they will have low hemoglobin, low white cell count, but you just have to be patient. And you have already started your GCSF, your granulocyte limiting agent, your erythropoietin, all the fuel, and then it will just shoot up. After day 10, you recover quite quickly. So don't panic. Just
yeah.
yeah,
I think
don't
it's a very clear message not to treat the number, isn't it?
Yes. Yeah. Don't treat the numbers. Don't. Most people are, edgy. They feel uncomfortable with such low numbers, but the patient is fine. Just go along. Yeah, they'll come out of it. Don't worry, they'll come out of it.
It seems like
And
the tolerance of anemia is the hardest thing, the cheapest, the hardest to employ. And you're right, tolerance of who? For the patient or the practitioner? And I think you hit the nail on the head. Oftentimes, the practitioner feel the need to do something. We just need to be patient and watch the patient. There is a question for Dr. Waters. Somebody wanted to know what finally convinced your team to abandon pre-autologous donation by 2014 in the example you mentioned.
What finally, we started charging patients for it because the patients demanded it. But when they were charged a cost for the pre-donation, it was easy to convince the surgeons that it wasn't effective, but convincing the patients was a different story. But when they had to pay, $300 per unit, all of a sudden they stopped demanding it. We later found out that that wasn't legal, associated with Medicare laws or rules, but it had the desired effect of eliminating it and driving it to zero. We do occasionally still do it, for those patients that do have those massive numbers of antibodies, but that's almost never, where it is a need. But at any rate, putting a dollar figure into somebody's lap will change behavior frequently.
Okay.
right. I think it comes back to our not treating the numbers. The first question that's there by Roslina. What's the best hemoglobin level to optimize prior to operation? Maybe I would like to invite Prof. Waters to answer this, because I think as anesthetists, we tend to face this quite a lot with our surgeons and their obsession with hitting the magic number of 10 prior to surgery.
Yeah, there's been some work that has been done on, what kinds of blood loss you can expect with a typical surgical procedure. For instance, I think Tim Hannon published a number of a drop of hemoglobin of 5 with a total hip replacement many years ago. So you want to have somebody coming into the operating room, with a hemoglobin trigger that's you're comfortable with, perhaps 7 or 8, plus that 5 grams of hemoglobin on top of it. That's one way of calculating it. So you'd want somebody coming into your operating room with a hemoglobin of 12 or 13. Another way of looking at it is through the MSBOS, which is the multiple, or rather the Um,
Major surgery.
yeah, thank you.
Blood ordering.
Yes,
Blood ordering
thanks.
system.
The blood ordering schedule that, comes along with many hospitals has MSBOS, and we started looking at our MSBOS, and there was very few patients that actually were transfused. I think it boiled down to about 10 DRGs or 10 procedure codes. And those are the cases that you want to focus on. You don't want to look at patients undergoing cataract surgery. It's a waste of time and money to be optimizing those patients. But if you got somebody coming for an aortic valve replacement, those patients are at risk of being transfused. And those are the patients that you want to focus on. So take a look at your institutional MSBOS, and strategize, focus on those particular patients. And I think you'll be better off from both a patient perspective and a cost-effective approach.
Right. Yeah. And I guess I think most of us will agree. This involves a lot of communication between the anesthesiologists or the anesthetists in theater and the surgeons. The level of hemoglobin level preoperatively is relative to how much I trust my surgeon intraoperatively as well.
Yeah.
Yeah, without doubt. So coming to the next question, there's quite a lot of questions about sucrosomial iron. It's something new to me as well. Maybe I've not been I've not kept in touch with oral iron. I've been using a lot of IV. Dr. Alicia, you mentioned sucrosomial iron. They've mentioned the few questions are about is it very expensive? Is it comparable with IV iron? Is there anything that's been any studies that have compared its efficacy with IV iron?
Yes, there are some studies that compare the efficacy in bariatric surgery, in colon surgery, and there are some study of cost effectiveness. Um, I don't know if you can access to sucrosomial iron in all the world. I knew that in the US you can use in some countries of Latin America, in Europe. I don't know in Malaysia, for example, if it is there. But I think I am using sucrosomial iron from 2019 in a lot of patients. And really, I think that is an interesting option to IV iron because IV iron is very complicated to use in uncommon countries like mine. The cost of the healthcare facilities is very high, so the insurance don't cover it. And it's very complicated for the patient because the IV iron is very expensive, the healthcare facility is expensive, so how can we do? The common oral salts have very bad tolerance, and you can reach the level of iron store you need before the surgery. And with sucrosomial iron, we really have very less intolerance. Less than 20% of patients have any intolerance, and we have very good results.
So how much is the cost difference between IV
Okay,
iron and oral and
here in
sucrosomial?
my country, one 500 milligrams of carboxymaltose cost 700 pesos. And 30 pills of sucrosomial iron you need for a perioperative period 3 boxes. Each box at this time is 70 pesos. The others 700 pesos.
So you've
So the
got
difference
about 200 pesos to 700. So it's about 3 times the cost.
Mhm.
I'm just wondering, Dr. Jamila, Sharon, Dr.
Mhm.
Jonathan, anything, is this similar in the US and in Malaysia? Is it available?
I do know that it costs a lot more than the typical oral iron that you can get over the counter, and ferrous sulfate that they often do have in-house in hospitals. I do know some people use it outpatients. It is a bit more costly, so I'm not quite sure yet how many places have really adopted it, but it does seem like something reasonable to look into, certainly. I don't know if you've heard anything more, Dr. Waters.
I just know that it's dramatically more expensive and our pharmacy has restricted its use. I do know that there is some reimbursement differences that may make it cost effective, but every hospital is going to have to calculate that for themselves.
Dr. Jamila?
We don't have it in our hospitals, but I think you can buy it online,
Yeah, because I was
Yes.
searching online, we could see it. But
Yeah.
it's very expensive. It's about 800 ringgit, which is about
it's very
200
expensive.
USD per bottle. So
Yeah.
that's quite costly, and it's probably cheaper to use IV iron in that sense.
Yeah. Yeah, I think it's sold as a food supplement, something.
Yeah.
Yeah.
Okay. The next question is actually for Dr. Jamila. Is it advisable or not to give IV iron along with ESAs even at normal iron stores?
Especially in functional iron deficiency, you can have normal iron stores, but you don't utilize iron. So you need to give a little, a small dose of IV iron together with the erythropoietin. That's what I do. Yeah.
All right.
Yeah.
Any other comments from the panelists before we move on? About using erythropoietin in normal iron stores, but patients with anemia but normal iron stores.
So I'm talking in the contents of, functional iron deficiency, where you have normal iron stores. But yeah. But what is normal? We did our normal range study, and we found that most of our patients have a range of up to 500. We did a normal range study in 2014 where we ran around the whole country taking bloods from adults, normal adults, and we found that the range is quite wide. I think the men 60 men in general have of course higher ferritin levels from 120 up to 500. Women who are premenopausal have a range of from 40 to 200. So the weight range is very wide. So what is normal? Yeah. When you say normal iron stores,
All right. Okay, that's good to know. Just going on to
can
another
I-
question. Sorry.
Okay, I wanted to add
Yes,
to
Nathaniel.
what. Thank you. I wanted to add to what Dr. Jamila, Dr. Satha has said. I agree with her completely. If, for instance, the patient is having erythropoietin, even if the iron stores appear to be normal, the erythropoietin itself can induce functional iron deficiency. So I think the hematologists have taught us that we need to give IV iron along with the erythropoietin so that it can be effective.
Right. Thank you, Nathaniel, for the comment. I think that's a very, very important. I don't know, maybe with the hematologists, you all are more comfortable with erythropoietin. I know from my own practice, I have to beg the hematologist and the nephrologist to even touch erythropoietin to be given to my patients, even though I say it should, but very rarely I've been given the opportunity. One of the questions that's quite recurring in the Q&A is about use of all these methods that we've discussed today in low resource countries. Any comments on this? We'll start with Dr. Villaseca.
Yes, I read this in the panelist question. Well, my message is you can do the best for your patient if you know. So probably we have not all the resources. In my country, there are some. In my clinic, I have a lot of research, but in other cities in my country, there is not the same reality. But if you know that iron deficiency exists, you know that anemia exists, you know that the blood is an organ you need to care, uh, some little change in your practice, um, take care the iron you can use. If you have not sucrosomial iron, you have not IV, use oral iron, but use something. If you have not viscoelastic method, but you know that the temperature, calcium, the control of pH, these are little things you can do that are going to make changes. The use of a simple situation that put your patient in the postoperative with oxygen delivery, for example, to control the pain. There are little things you can do all the days. And sometimes when you have the other research, you have the material to do better, but you can change the situation with little things.
I really agree with that. We have to take small steps, which whatever, looking at what resources you have, and take small steps towards
Absolutely.
achieving. And it's better to just take that one first small step than not to take the step at all.
I hear last month a lecture about how to do the implementation of a guideline of PBM. And the doctor says you need to do your guideline using the research you have. Because if you want to use all the research and you don't do anything, you are doing no change. So you
Agree.
need to use the guideline to guide the change in your institution with your research.
All right. Okay. Dr. Jamila, any comments from you? You've taken us through 20 years of trying to
Ah,
change. Small steps in
ah,
20 years.
a big challenge, isn't it? Yeah, we're still pursuing, never give up. Yeah. I think we start with whatever we have. Say if we don't have cell salvage, or start by optimizing the patient first before they go into surgery, with IV iron. I think we start small. I think in Malaysia we have everything, So just that we need to get people on board, to practice patient blood management more widely. I think people are afraid, afraid to change. Yeah. But we've got all the evidence. So, we just need to, you need to just practice it, and then you gain confidence, Yeah. Just
Any
Maybe-
advice,
Yeah.
Dr. Jonathan? Oh,
Yeah.
sorry. Is Nathaniel back with us? Dr. Jonathan?
Yeah, I was going to say, I mean, in the surgical world, unwashed salvage blood doesn't take a lot of technology. And it was pioneered in the Western world in 1874, and it was the primary way of transfusing patients undergoing surgery for about 50 years. It's gotten a bad rap because people think that unwashed blood is dirty, but kept in low quantities, I think it's perfectly adequate, and it can be used in third world settings or settings of low resources. And so I'd look at that as a potential alternative. Um, and the way they did it in 1874 is they simply filtered the blood through gauze. I think you can probably be a little more sophisticated than that. But look at historical practices because I think you can learn a lot from those ways of approaching the problems that the Western world faced 100 years ago.
Right. I think we're almost nearing the end of our session for Q&A. It's been really great. I just one last comment, and this is a policy question. Do you think that auto transfusion is highlighted enough in recent PBM strategy, which was recommended by WHO? The thing is, many hospitals in Slovakia do not support this option since it wasn't used or requested previously. Do you think that auto transfusion will be more stressed upon in the future? I guess Dr. Jonathan, and then we'll.
Yeah, I have pretty strong feelings about this. I mean, I think, societies like Natal or Sabum, have focused on trying to garner dollars from drug companies to support their existence. And the companies that have money are the ones that, produce intravenous iron and erythropoietin. The companies that make auto transfusion equipment, they're very small margin companies, and so they tend to not have the same presence. But I think, at least in the surgical world, it has the greatest power to avoid a transfusion compared to any other strategy. And like I said, I took my father through a 13-liter blood loss without blood. That's what you can do with cell salvage. And you can't do that with, pumping up their iron, and you can't do that with, erythropoietin getting their hemoglobin to 15. But you can do it with, just recirculating their red cells. And I think it has been given a short um, or not enough attention, specifically because the dollars on the table don't speak loud enough.
Dr. Jamila?
Yeah, I think you, Kevin, you should go and look for, those simple, filters,
Well,
instead of having, yeah.
I'm already having enough trouble trying to convince my surgeons to use an actual cell saver than to create my own, It's been a challenge. It's still a challenge. It's only in
Yeah.
spine surgery that my spine surgeons have been convinced, but the rest of them are still 50-50. Right. I'm going to hand over back to Sharon. I think we've got some videos to watch. Last comment from Nathaniel. His hand has been up for the longest time. Sorry, Nathaniel. I just saw that. Any comments, Nathaniel? Before we proceed
Oh
with the
yeah,
videos?
thank you. Yes. Sorry, my network was fluctuating because I was moving. So the question about auto transfusion, certainly acute normal volumic hemodilution or blood salvage, as Dr. Waters has outlined, is very important and very useful. But it has to be for high volume surgery for it to be cost effective. That is, a patient losing more than 1,000 mils. Secondly, some people, when they're thinking of auto transfusion, they are thinking of pre-operative autologous donation. That one is not scientific because it's going to lead to the same storage lesions as donor blood, and therefore will still lead to high morbidity and high mortality because it causes hypoxia instead of improving tissue oxygenation. And furthermore, many other problems can occur whenever blood is stored in the bank. There can be clerical errors, bacterial contamination, and so on and so forth. So when we're talking of auto transfusion, we have to have it in mind that we are only talking about we're only talking about blood salvage, cell salvage, and acute normal volumic hemodilution.
Okay, thank you so much, Nathaniel, for those final comments there. So we're going to go into our video portion. We do have two small short videos around bloodless medicine. The first one we're going to see is called Bloodless Medicine and Surgery, What You Need to Know. And this is featuring Dr. Steve Franks down at John Hopkins down in Maryland. We can't hear. Sarah, please make sure the microphone is not muted.
She's going to share sound.
Okay, thank you.
Let's see to share sound.
Mhm.
Providing bloodless care to patients is simply providing medical care without giving patients blood donated by another person. The way we do this is to conserve blood by reducing or eliminating bleeding, by stimulating the body to make its own blood cells at an accelerated rate, and also by recycling blood that patients lose during surgery and giving them back their own blood. Well, there are several reasons why patients may choose a bloodless approach to their surgery. Historically, patients have elected to avoid transfusion because of religious reasons, but also some patients just simply wish to avoid the risk or the side effects of transfusion. For example, we know that patients treated with the bloodless methods have a shorter length of stay, decreased incidence of hospital-acquired infections, and also less chance of an allergic reaction or even receiving the wrong unit of blood, which still occurs. The first thing we do is we diagnose or treat anemia prior to surgery, so patients come to the operating room with enough red blood cells so they can tolerate any blood loss. During surgery, we can avoid hypothermia or hypertension, both of which can increase bleeding. And then we can collect and recycle the blood they lose using the cell saver and give them back their own blood during surgery. We can also use what we call ANH, acute normal volemic hemodilution, which is where we bank the patient's own blood at the beginning of the case and give it back to them at the end of the case. There's one more technique. There's new versions of electrocautery that have come out recently that can dramatically decrease bleeding during orthopedic cases and during spine surgery, for example. Virtually 99% of all the procedures we do can be performed without transfusion. For example, we've done some really big surgeries like a Whipple for pancreatic cancer. We've done many of those without transfusions. We've done open heart surgeries, even revision open heart surgeries for valve replacements and bypass surgery without blood. And recently, we even did a 6-kilogram baby, that's about a 14-pound baby, who had open heart surgery for tetralogy of Fallot, requiring cardiopulmonary bypass without a transfusion. We believe that we offer more different types of specialty care than any other hospital in the country that has a bloodless program. Plus, our program blends seamlessly into the care plan that's offered by all varieties of specialties within the hospital. Surgery itself is becoming less and less invasive. For example, the laparoscopic and robotic approach to different surgeries have dramatically decreased the amount of blood that patients lose and the amount of transfusions they require. Also, we're giving new intravenous medications like iron, or we're even giving erythropoietin, which is one of the medications that the professional cyclists use to blood dope. Only now we're giving it legally to our patients to build their blood counts prior to surgery so they don't require a transfusion.
So now we'll see another video. It's entitled How It Works, Bloodless Medicine and Surgery, an Alternative to Blood Transfusion. Thanks, Sarah.
Every year in the U.S., patients receive 21 million blood transfusions. What if there was a better solution with significantly improved outcomes?
So nearly every surgical procedure involves some degree of blood loss. And traditionally, we give patients blood from the blood bank. However, another option exists, which is called bloodless medicine and surgery, where we use alternatives to transfusion.
Techniques performed before, during, and after surgery result in minimized blood loss, faster recovery, fewer infections, and quicker discharge. Bloodless medicine eliminates the need for blood transfusion, thus avoiding the dangers of allergic reaction, contamination, and the possibility of receiving the wrong blood type. Before surgery, medication and nutritional supplements increase hemoglobin levels, which help your body handle blood loss during surgery. A process called hemodilution temporarily replaces a portion of the patient's blood with fluids, lessening the impact of blood loss during surgery. Tools and techniques used during surgery include anesthesia processes to safely lower blood pressure. Harmonic scalpels clot the blood while cutting the tissue. Cell salvage machines collect lost blood, wash it, and return it to the patient. Hemoglobin monitors reduce the need to collect blood samples to be sent to the lab. After surgery, medications and techniques can minimize bleeding and improve oxygen in the blood. Often after surgery, blood must be drawn to run follow-up testing in the lab. Microsampling requires 1/10 the amount of blood traditionally drawn, reducing the amount of blood patients lose by almost 90%. At Johns Hopkins, our team of highly trained experts have been providing patients alternatives and peace of mind for years.
Right. Thank you. I think the videos clearly highlight the importance of bloodless medicine in surgery, in medicine and in surgery. Sharon, would you like to take us through tomorrow's schedule?
Yes, we're going to have a great day tomorrow. And the topic of sickle cell anemia is at the forefront, which for us on the call Bloodless Medicine, we know that that's one of our most challenging situations. It affects pediatrics and very, very challenging, often very tense situations. So it's going to open up with old and new options for bloodless care of sickle cell patients. We're going to also then move into bloodless medicine and surgery for patients who have sickle cell. So again, whatever special considerations may be needed for that population, and then advocacy. Bloodless medicine in and of itself requires strong advocacy. How much more so when you care for someone with sickle cell disease? So we're going to hear a warrior's perspective tomorrow on that. So we look forward to you all being here.
Yep. Sounds like a great, very interesting day tomorrow again. Thank you everyone for joining us, and thank you to all our speakers and my co-moderator Sharon. It's been great having all of you here, and I hope you've learned something and enjoyed the session. I would say any shortcomings, I do apologize, especially our little technical issue at the start. But thank you again, and you've been a great audience. Thank you all.